So now we're moving on to, I suppose, I talked earlier about patient public input, and I suppose that what we're moving to now is perhaps the lived experience. So Mandy Daly is going to speak to us. I think her topic is fantastic. Prematurity is for life, not just the neonatal unit. Mary's Eve, a Patty Fellow, a medical and disability underwriter. She is the parent of a preterm baby, which she'll talk to you about. And set up a collaborative multi-stakeholder platform, the Irish Neonatal Health Alliance, in 2013. She has quite an international profile in advocacy, education and research. She's involved in education to medical nursing staff, professional students, mentoring PhD students, involved in the PPI Ignite Network, the European Foundation for the Care of Newborn Infants, and the NPEC Federation. She's a published author in quite a few significant journals, including the Lancet, British Medical Journal, and others. And we're really looking forward to hearing you speak, Mandy.
Good morning, everybody, and thank you to NPEC for inviting me here to speak, and also for your continued support and your continued engagement with the PPI community. I'm going to give this a go and see what happens. Okay, so my name is Mandy, and I'm the co-founder of the Irish Neonatal Health Alliance, which is a patient advocacy organisation. It's founded out of my experience as a parent of a preterm infant. This is Amelia. Amelia was born at the end of week 25 in 2006 after a placenta abruption. And we're all familiar with, the famous preterm babies, the Einsteins, the Isaac Newtons, the Winston Churchills, who left an indelible legacy on our world. But there's also those who didn't spend a lot of time with us, like the Kennedy son, who survived 39 hours after being born. He was born with respiratory distress syndrome at 34 weeks. Ventilation was only just coming on board. I think 9 months before he was born, he was unable to be saved, and he did pass away. What did come out of his short time with us was an increased investment in neonatal research, which ultimately ended up in surfactant being discovered, and surfactant is what saved my child. So interestingly enough, we have a weird connection with the Kennedy clan. So the theme of today being continuum of care, and I suppose the theme, it got me thinking, preterms are never what you see. What you see when a preterm infant, when you see them in adulthood, that phenotype, there's so much more beneath the surface. There are so many layers that we don't see and that we don't often consider. They're quite a complex group of people, and a lot of them have interesting contributors. So the parental journey, the parental experience, what Winnicott said was there's never an infant without a mother. And what that really means is the maternal journey and the infant journey are interlinked, and that they both need to be considered right throughout the continuum. I guess, where does the continuum of care start? Who's responsible for it? Who continues it throughout the lifetime of the child? Is it a lifetime thing? Does it come to an end at some point? I don't know. Maybe that's what we're here today to discuss. So I suppose, as I said, the adults we're seeing now coming through, they're a small group. We don't follow them up, but they are gaining a voice. For us, I've gone through the antenatal, the neonatal, the early childhood, and my daughter now is 16, turning 17. So I've lived most of the journey, but what's ahead is kind of an unusual one, I guess. So what is care? The beginning is the most important part, as Plato said. Care, it's multifactorial, it's multi-stakeholder, it's interdisciplinary. And some of those key elements that are involved in care are collaboration, communication, action, education, and it has to be dynamic. And it's similar to mathematics. If we don't learn the fundamentals, those little building blocks, we miss out on something very important. The ultimate structure is never going to be as strong as it could have been. I remember years ago hearing a Greek neonatal or obstetrician talk about the pyramid of care for obstetrics, and he had flipped it so that the majority of the care took place in the first trimester. And I was very impressed with him because he was looking to the future and saying, if we can do more in terms of prevention, we can actually prevent an awful lot of the stuff later on. And his name was Kipros Nicolaitis, and he's still impresses me today. I'm seeing more of the screening happening now, the first trimester screening, and I'm so excited to be involved in a lot of it, but I think we need to do a bit more. What we do as an organisation in the INHA, we look at preconception and say, okay, where are those education gaps? Where are those knowledge gaps at present? And for me, when I got pregnant with my daughter, I knew nothing. Even though I was a geriatric mum, I hate using the term. So what we're doing now is we're trying to have those conversations with primary school kids, with secondary school kids. We go in and we talk to TY students every year now as an organisation, and we introduce them to the concept that pregnancy isn't all that they think it might be. We get kids in a room of 150 kids, we get every 10th child to stand up, so we can demonstrate that 1 in 10 babies are going to be preterm. We bring in a pound of butter and an 8-pound bag of potatoes, and we send it around the kids, and you can see them weighing it up. So it's to give them that sort of tangible concept, yet also introducing that element of education for them. So at some point, somebody in the room is going to have a preterm baby, and at least they've heard the term, they have a very basic working knowledge of it, and that would have helped. Even the first trimester, antelatally, I can understand why a clinician is reticent to have conversations about high-risk pregnancies. You don't want to upset people. But when I was at 36,000 feet in the air, in an airplane, in labour, I wish that my obstetrician had said to me, have you a family history of preterm birth? I did. I had a really spectacular family history of preterm birth, but I didn't offer it up because I wasn't asked the question. So I think we need to balance those risks. I mean, I was 36, I was an older mum. I had bled throughout my pregnancy. I was being seen weekly by an obstetrician, but the preterm birth was never discussed with me. And, I buried my head in the sand, like we all do very well, and ignored everything that was happening. So I suppose it's finding that balance between not going over and over upsetting the family, but also they need to be part of that conversation. They need to be educated, I think. And I think that's one of the areas we would like to see some improvements. How about my journey? Okay, I'm not going to say too much about the NICU journey because that's probably the most supported part of my journey for me. I'm surrounded by an amazing team of specialists who are doing all the tough stuff. What I would say is that it's a really good opportunity for staff to educate and to inform families and to prepare them for home. Things I would have loved to have known, Professor Dempsey mentioned it earlier, sleep. I give a whole hour talk about sleep these days. I knew nothing about sleep for those 4 months we were in NICU. I came home and I knew nothing about the importance of sleep. I knew nothing about neonatal brain development. I knew nothing about neurobehavioural cue reading, all of which would have made me a much better parent when I would have got home. I sat back passively and let people do the work for me, went home, was discharged on Christmas Eve, probably not the best time to be discharged, fell between the stools. My notes didn't get to the community support. There was no contact with public health when I got home. It was really scary. My child constantly had apneas. She stopped breathing all the time. At the door of the hospital, I went from being the mom to the neonatologist, the NICU nurse, the OT, the SLT, the dietitian, the physio. And somewhere between all those roles, I too had to be the mum. And it was the scariest time ever. And going home and having no contact and having no transition period and having no bridge between the NICU and home. At the time, I was just muddling my way through it. And about 3 weeks later, I realised, oh, the public health service hasn't contacted me, and I was reaching out to get support. But what I did find was when I did reach out to those entities, be it the GP services, the primary care, the public health nurses, the minute I started to talk about Amelia's history, it was like the shutters came down. You could see them going, oh, I can't be dealing with that. That's very complex. You need to go to either, my GP kept on referring me to A&E every time Amelia had a sniffle. I stopped going to the GP. The public health nurse, to be fair, said, I don't have the skill set to support you. She did her best, but she was very open and honest. And I think there are some of the gaps. In terms of continuing care, we do have gaps that need to be addressed. And we do need that really important transition period for families. It doesn't happen. It still doesn't happen. And as an organisation, we still have families coming to us feeling isolated, feeling cast adrift. They're not fitting in anywhere. Primary care is is kind of sort of saying, yeah, I'm not sure, I really don't want to get involved. That kid is complex. Maybe you should go to ED. I don't want to be sitting in an ED. I did it over Christmas with my 16-year-old. Certainly didn't want to do it when she was really small. So I guess, yeah, there are certain elements of that discharge process that needs to be addressed, you know. When I did get Amelia home, what was it like? There were lots of things happening to her that I didn't have words for. I didn't understand why she was really sensitive. She was very sensitive to noise. She was sensitive to light. She loved certain textures. She loved vibrating toys. She had a meltdown if you came within 2 meters of her. Her feeding was problematic. It always had been problematic in the NICU. She'd been intubated for 4 weeks. What I didn't realize was that she had developed an oral aversion. And every time I was forcing a bottle into her, having already expressed it, I was making it worse. I was overstimulating her. She was getting upset and then throwing it back up. So it became a really difficult cycle of expressing, force feeding, for the want of a better word, and then her vomiting up, and that 3-hour window had evaporated, and then we were back to the whole expressing thing again. So feeding was very difficult for both of us. She certainly didn't have any positive experiences. And again, there was something I didn't realize in the NICU. I didn't know anything about sensory processing disorder. It took me 3 years to actually get a diagnosis for her, even though I kept a diary every day since she was born. So when I now read back on it, all the signs were there. All her journey through the NICU, she was screaming out that she was stressed and she was overstimulated. I sat at the incubator doing nothing because I didn't know any better. And the staff didn't know any better. We didn't know about reading infant cues. We didn't understand neurobehavioral cue reading and how to respond appropriately. So I suppose, you know, in hindsight now, we're better where we are now, but I still have families who tell me they don't know what the child is saying to them. Apart from feeding, Amelia had BPD. And whilst I knew she had it, I had no idea what it was and how it would affect us. So BPD was kind of like a term that was thrown out during conversations. But when she came home, she just went from chest infection to chest infection, from antibiotic to antibiotic. I'd say for the first 3.5, 4 years, she just cycled through antibiotics every single month. She did not sleep. She never slept in the unit. She certainly never slept at home. What I did notice over time, though, was if I slept with her, as in I sat up and I sat her in front of me, she was much more comfortable. And then it transpires, BPD babies don't like lying on their back. It's uncomfortable for them. So I was forcing her into the lying on her back because I didn't want her to have SIDS. She was struggling to breathe. She was waking all the time. Her sleep pattern was completely disrupted, which we know affects brain development. So it was almost like a vicious cycle of stuff that I didn't know about. And in hindsight, it was easier for me now to look back 16 years later and draw and kind of, you know, connect all the dots. So these are things I think families need to be part of those conversations earlier on. Her motor skills were very problematic from early on. She certainly had issues with her gross motor skills, her fine motor skills. We were working on it. And at one point, the OT turned around to me when she did start school. We did a lot of work with the OT and holding a pencil, and the school were very insistent that she held it their way until the OT just said to me, do you know what? There's some battles you're not going to win, and this is one of them. She's going to be typing the rest of her life. And I had to advocate on behalf of my child. When she went to school, I had to have those conversations with the school. They had never had a preterm baby before. The day she started, I had met them months in advance. I'd given them the big medical file, and they were expecting a small little waif-like kid to arrive in, and she's far from waif. She was the tallest in her class. And all they thought was she was going to be small. And when I tried to talk to them about, you know, the issues she may have going forward, that shutter came down again. And all I could see was over-anxious mum, only one child, nothing better to do with her time. And that persisted right through the entire primary school years. It was really difficult to have them understand. And what we've done now as an organisation is we now go into Mary I in Limerick and we give a lecture because we're trying really hard to have preterm birth included on the syllabus for primary school teachers. It is so important. They meet so many of them, but they don't know what to expect. So, as a young adult, where are we today? So Amelia is 16, turning 17. BPD has become a little bit easier to manage. She's gotten bigger. Her system is a bit stronger. As I mentioned, over the winter period, she got RSV eventually. It took 16 years. I mean, it was the one thing I was so scared of when she came home was she'd get RSV and she'd die on me. She got it at Christmas and we did have to go into ED. Having those conversations with the emergency services and the staff in A&E about BPD. I saw that shutter coming down again. I was trying to explain her birth story, her difficulty, how BPD affected her bronchioles, how she was hyperreactivity in her respiratory system, and I could see I wasn't being heard. And that was really hard. So those kids, they have that prematurity with them for life, but there are certain agencies who, not through any fault of their own, don't have the education and the information to react appropriately. And I spent a lot of hours in ED upskilling people, you know, eventually screaming and shouting. The only person actually who would listen to me was the paramedic in the ambulance who brought us to hospital, and he was absolutely incredible. He was so open to sitting and letting me say, okay, I need you to do blood oxygen levels, I need you to do her BP, I need you to check her aortic valve. And he was like, whoa. And I went, please just do them, and then we'll have a conversation afterwards. So I think that communication and listening to families is so important. Amelia has an amazing ability to react to pain, and it definitely relates to her time in NICU. She has a really, really low pain thresholds, to the point that when something happens in school, the school are ringing me and they're saying there's something seriously wrong. And I'm like, okay, did you just fall? So again, we have to be very cognizant in the NICU that everything we do in the NICU has an effect. It can be positive, it can be negative, but it's cumulative either way. And that also stays with the kids throughout their life. Amelia's sensory issues still continue. She has really interesting quirks when it comes to touch. Smells are really serious for her. So if somebody has a yogurt in school or has an orange, she vomits at will, and that still persists. Trying to get that conversation going with schools is really difficult. They ring you to say, so she's thrown up, and you go, does somebody have an orange? You know, and I know they're going, oh my God, that's what they're talking about. But that's my world. And I guess, you know, it's again, through no fault of their own, it's unusual, but it does happen. Amelia's circulation is becoming an issue. She's 16. She had hemangioma diagnosed at 6 weeks in her left foot, and it literally destroyed the architecture of her foot. She's lost her toenails. Her toes they're claw-like. Her foot is quite distended, it's quite deformed, and the circulation is now becoming an issue. She has old lady's feet. She goes to the chiropodist every month. You know, she's 16. And I see her looking at her feet, and I know her self-esteem is being eroded by certain little things. It's eroded by her inability to eat. She still eats very soft food. She'll eat white food. She doesn't like mixing her food. Textures are problematic for her. She'll eat food at the front of her mouth. It's almost like she's testing it before she swallows it. So she's got a really good group of friends who support her. But when they're going out, the girls have to think, you know, is there something there that Amelia can eat? And I know that's obviously going to become more problematic for her as she grows up. I can't always be her voice and her advocate. School in secondary school has got no better. You know, again, having those conversations that these children have ongoing issues is difficult. She's graded in PE as always poor. You know, she's got dyspraxia. She has sensory issues. She has BPD. She has cardiac issues, which I'll speak about in a little while. And then she gets a poor grade in her PE. The kid can't do it. She does her best. And having those conversations of, you know, stop benchmarking the kids against the normal term baby. She's a preterm baby. And do you have any idea how damaging it is when a kid who does okay academically, apart from maths, sees this poor performance in PE and she tries her best with the school, like she's not meeting the grade. But yeah, but that grade is a term baby, like, you know. So again, it's just that lack of understanding, I guess. I do a lot of research with Eleanor and Professor Dempsey and a whole bunch of others. And recently I was working with Orla Franklin in Crumlin on a heart study. We were just looking at the heart structure of ex-preemies against full-term babies. And sure, I put Amelia into it because she met the criteria. And we all sat looking at the echocardiogram, horrified at what we saw. Amelia has never had a blood test since she left the NICU. She had her first one in ED recently. She's never had an echocardiogram since she was in the NICU. She's never had anything. She's had a whole bunch of antibiotics, but no intervention, no MRI, nothing. On her echocardiogram, we saw a failing aortic valve, very impressive incompetence, very impressive regurgitation. And we all sat there going, oh God, that was unexpected. And that worries me because, okay, I'm lucky. We've got that detected at age 16. Where would that have gone At what point will we have found this out? Now we know what we're dealing with. And I think knowledge is power in these circumstances. It's really, really important. So what is research telling us? Well, I had the privilege recently of having Dr. Suraj Sagal speak at one of my medical days and World Prematurity Day. And she's done some really interesting longitudinal studies. And her assessment measures include cognition, the children's school achievement, their executive function, of which Amelia has none, and behaviour. Then she's looked at adolescents, looking at their accomplishments, their independence, their self-perception, their mental health, which is really, really important, because I will go back to that later. This is something we don't put enough emphasis on, and their quality of life and their aspirations. And then in adulthood, obviously, the things like cardiovascular, metabolic sequelae, psychiatric, visual disorders and reproduction. And no surprises, we've already heard about the early years, the delays, the speech and language, the neurological problems. But what we're looking at in school years is that they do have lower IQ. At a quarter to a third of them have learning difficulties, and especially those early preterm babies. And 57% of 7-year-olds don't meet their targets in reading, writing, and maths. Sorry, they do meet them versus the 82% of term babies. They have serious difficulty with executive function. And again, trying to have that conversation with the school as to why my child can't organise herself and why she becomes distracted. It often translates to something else when a teacher sees it. And I get it, teachers have 25 to 30 kids in a class. But I think if they had that knowledge at outset about a preterm infant and what the long-term consequences for, they may approach them differently. And I think that would really help. We see a lot of kids with ADD and ADHD, especially boys. And these two boys are in this photograph. They're both 7. They're brothers. And obviously, one is very severely growth restricted, and he's now 25 and is no better, I might add. So, he's still continuing to bear the brunt of preterm birth. In adolescence, again, the lower IQ and the learning difficulties continue. And the rates of those difficulties actually far surpass what we're seeing in neurodevelopmental impairment. And obviously, in terms of an economic analysis, we see that after the NICU, educational support is actually the greatest cost factor. What I'd like to quickly bring you through is the Premature Infant Skills and Mathematics website. It is an amazing resource by Dr. Samantha Johnson. It's aimed at teachers who teach maths, but honestly, anybody outside of a NICU setting needs to go onto this to learn what is preterm birth, how does it affect the children, and what areas of their development is affected. Mathematics, which I've said, is a huge problem for preterm babies. It's the only thing Amelia struggles enormously with. She just doesn't get it. It just doesn't happen. It's like that part of her brain hasn't been switched on. This particular website is amazing. And we push it so heavily in Mary I at the moment. We're trying to get them to include it as part of their syllabus because they're hungry for information. What we're doing is we're reaching out to other agencies who are non-NICU, and they're telling us we want to learn, we just don't know where to start. Again, Dr. Sagal's adults, they tell us that very few of them were fully employed. Their personal income is lower, their total household income was lower, and early preterm women are less likely to be fully employed. In the Bavarian study, again, we're looking at their IQ and executive function. It's below the control group, and they have decreased cerebral volume. We know from Dr. Marlowe and Dr. Woke and McKay that there is a direct correlation between gestational age and outcomes. In the Norwegian preterm birth and reproduction study, the stillbirth rate amongst ex-preterms outperforms their term counterparts. They reproduce less, they have more recurrent preterm births, and they have fewer subsequent pregnancies. These are conversations I have not had with my daughter. I know they're all down the line, and I know she's going to have to manage these at some point. And I think for our adult preemies, there's a lot to take in there, and there's very little support for them to deal with this information. And again, we know that their height and weight differs from their term counterparts. This is a very important one. Looking at their blood pressure, with their systolic blood pressure, the difference of 5 millimeters actually means a 34% increase in mortality due to stroke and increased risk of ischemic heart disease. Again, it was also looked at by the NPEC Corporation. The McMaster prevalence of dysglycemia in preterm infants is very important. I have adult preemies now coming to me who have been diagnosed with type 2 diabetes in their early 20s, and they don't know why. They have no family history, they have no lifestyle issues that would contribute towards it, but they're now managing issues. I'm going to call them geriatric issues for the want of a better word, but they're managing issues that we associate with the older population much, much earlier. And this is worrying because they are having difficulty when they are presenting because their consultants are dismissing, for want of a better word, their preterm birth. And this is the conversations that are being fed back to us, is we are being dismissed. When we try and raise a conversation about I'm a preterm baby, you're told that's in the past, that ended at age 2. And that is the biggest lie that happened to me. I was told when she reaches age 2, it'll all get better. And you're holding on to that. It's you know, it's a couple of months down the road, it'll all be fine. As if someone's going to wave a magic wand at age 2. Doesn't happen. And then you're thinking, she'll sleep by the time she goes to preschool. And then like, no, it'll be primary school. It just doesn't happen. And I think, you know, it's soul destroying. It's difficult enough being a parent with a kid with complex needs without having these little carrots put in front of you that never materialize. Very important. We're looking at mental health in our ex-preemies. There are several studies which are telling us that they have significant increase in psychiatric disorders, ASD, ADHD, psychosis, bipolar. There are so many studies out there telling us this. They have 10 times the odds of ASD, they're 5 times the odds of ADHD, two times more likely to have anxiety, depression, 1.5 times more likely to mood disorders. So what's been done about it? Like there's a load of research, but there's no action. What we've done in a very small way, and I don't proclaim it to be an answer, but it's one of the measures that we've taken to address it. Myself and some other patient organisations from France, Greece, Hungary and Lithuania have come together. We've got some Erasmus funding and we are developing what's called a Prenate Hub. And it's for all those agencies who are not like yourselves, who are not frontline NICU workers, who will not see a preterm baby in the acute setting. But you might be a teacher, or you might be a community-based physio or an OT or an SLT or a social care worker or an early school teacher or a secondary school teacher, and you want to learn more and it's not part of your syllabus. So what we're doing in each country is we're setting up a website, we're going to have webinars, and we're going to put some resources there for all these agencies so that they can learn and upskill themselves and be better at doing what they do every day, with the result that our preterm babies won't be treated as differently, but there'll be a knowledge on the part of those people that they will interact with, that these children think differently. Amelia thinks differently. Amelia will only learn if she's walking or she's bouncing or there's music playing. She has different needs to regulate herself. And even the words using regulation with teachers in school, like, you know, the kids have to sit down, and you're thinking, well, okay, not all the kids actually learn well when they sit down. They all have individual needs. And sometimes, you know, even understanding why they have those needs and the importance of facilitating those needs can have such an impact on a kid's experience of school. So the Prenate Hub is just launching this year. Yeah, anybody would like to promote it, please do. I think it's really important because I think we're great at what we do in the NICU. We do an amazing job. We are really good at making these kids survive, but I think we still need to do a little bit more in terms of helping them thrive. This is Lauren Ingledow. Lauren's 34. She was born at 26 weeks and she was 1 pound. Her mum had preeclampsia. Lauren has spent her entire life battling against the education system, the health system. She's an incredibly articulate young woman who knows what she wants and who asks questions. Unfortunately for Lauren, she has met with so many obstacles to the point that she recently founded the Adult Preemie Advocacy Network. It's a global website and Facebook group. She's now offering a platform for people who, like Amelia, in a couple of years' time, may need to go and find others like herself. And she is having conversations with people and saying, okay, what hasn't worked for you? What were your difficulties? And they're finding so many common ground and they're working together to make a difference. Lauren is here today virtually. I know she's listening to us and I know I can hear her voice in my head going, tell them this now and tell them that and tell them I'm sick of all the research. I just need to see more action. She's incredible. I can hear her and I know she's laughing, you know, saying this. So what are they telling us? What are they telling Lauren? They're telling her they're having problems with cardiology, gastroenterology, follow-up, immunology, mental health, respiratory issues, renal issues, ophthalmology, neurology. Like Lauren is apparently type 2 diabetic and she's got chronic renal disease. And she herself tells me she monitors her blood glucose and she's going, I'm not type 2, I'm dysglycemic and it gets worse when I'm stressed. She is so familiar with her own body. It's incredible. Yet every single week I'm hearing stories about her difficulties being heard and having conversations about her birth journey, because people aren't understanding. They're dismissing it and they're telling her it's in the past, it doesn't matter. She's also introducing a lot of her platform members to some of the research that's happening globally, because it's really important that research continues. We do need to keep gathering data. So there's several really good studies happening, and she's connecting her community with the researchers so they can actually come together collaboratively and make a difference. So what about my future and Amelia's future? Well, we've done the neonatal unit. We navigated the early years just about. We're kind of hovering in between young adult and adult at the moment. She'd probably say adult, but that's up for negotiation. I don't know what's going to happen in the future. I have an idea based on the research. It worries me because I know the supports aren't there. Will I have to have that conversation with her? Yes, I probably will. I don't want to have to tell her that if she has a baby, it might be preterm. I don't want to have to tell her that her chance of stillbirth are increased. She's had a pretty tough life. I've sheltered her from most of the stuff. She's involved in the cardiac issue now because, you know, she's a little bit more aware. What she didn't realize when she was in ED recently, but my concerns were because she had RSV, she was violently coughing for about a week. I was really worried about the heart valve. And I kept on when AD saying, can somebody please just listen to her chest, do an ECG, tell me what you're hearing, you know, and you're trying to say she has an aortic problem. And I know ED was really busy. And actually what I've done in the meantime is it's actually bought my own stethoscope, you know, and I'm actually going to learn how to listen to her heart sounds. And no parent should have to do that, but I'm doing it on her behalf. I hope things are going to be better for her. I think the research is telling us that they do have lifetime of problems. I think where we need to act is actually how do we connect all the dots? How do we bring that care from preconception right through to adulthood? How do we identify those kids that are going to need that constant monitoring? And it looks like it is those really early preterm babies. Who's going to do that? How do we start that conversation? And I think even just looking at those small line fruits, those small little wins are really important. Having those conversations with those agencies, like school teachers, you know, community-based healthcare professionals, community-based AHPs. It's a start, but I think it also needs input from those of you who work within the field to help deliver that message. Because, okay, I'm a parent, I work for this organization, but sometimes it helps to have a team behind you. So I would say, please consider some of the opportunities that do arise. And if an opportunity arises for you to give a webinar to your community-based AHPs or your community-based healthcare professionals, seize it, because the impact, you will not appreciate the impact on the patient ultimately. So I guess I'm going to finish up before I get thrown off the stage. But saying the future depends on what we do in the present. So thank you for your time.